As always, things keep changing and shifting. We continue to monitor the global numbers, and Dr. Yaffe may talk about some of those briefly. The general context is that we're still seeing rapid rise in cases in the U.S. As their situation evolves, and we continue to monitor that. We are, as well as the rest of our provincial territorial partners, are having just their first cases in some of the territories, and some provinces like BC and Quebec are seeing large numbers of increases in their cases. Quebec had a large increase yesterday, but we understand that was somewhat due to laboratory backlog reporting. So, but that still is a significant increase for our partner to the east of us in that regard. So we see this ramping up across the country, and each ones are facing the same challenges of the need to do more and more testing, but capacity issues in that regard. So we're all working at how to improve that, how to impact a wider surveillance model, and to keep up to date as we see this change, especially with the number of people who have returned to Canada, the people who are still returning to Canada in that regard. So before I go into those wider issues here, I'm going to ask Dr. Yaffe to talk about our data here from that as we have present with us today. So over to you, Dr. Yaffe.
Okay, thank you. So as of this morning, Ontario has confirmed a total of 588 cases of COVID-19. This is an increase of 85 since yesterday. Unfortunately, we have had a new death related to COVID-19. This is a man in his 90s who was a resident at Hillsdale Terraces in Oshawa, who had recently been confirmed at COVID-19 and passed away on March 23rd after being transferred to Lakeridge Health, Oshawa. Of the 588 cases, exposure information as to where they might have acquired it remains pending for just over 40% and still being investigated by the local health unit. Of those where we do know exposure, about 65% had traveled, 20% were a close contact of a case, 13% there was no history of travel or known exposure to a case, so we can comfortably say they were transmitted in the community locally. Of those who traveled outside of Canada, 29% had traveled to the United States, mostly New York, Colorado, California, Florida, and Nevada. Most common second destination was Europe at 28%. So it's interesting to look right now that Europe has had a total of over 201,000 cases, which is far larger than China that has 81,000. So it has surpassed that. And it has surpassed that in deaths as well, with 10,731 deaths in Europe compared to 3,277 in China. The United States as well, over 46,000 cases and almost 600 deaths. In terms of hospitalizations, the cumulative number to date is 5050. It's gone up by 11 in the last day. Cumulative number for intensive care unit patients has been 17, with an increase of 5. And of those patients in ICU, of the adult patients, 7 are vented or are intubated, none in the none in the pediatric age group. And we are aware of cumulatively now 31 healthcare workers who have been infected with COVID-19 with an increase of 5. Thank you.
Perhaps you want to explain the difference between cumulative and current.
Okay, sure. For those who are not into math and epidemiology, cumulative means the total number that have been reported since the beginning of measuring for COVID-19, which was basically in January, I guess. So that doesn't mean they're all still sick. It means that's the total number to date, whereas the current number is the number that are as of today or as of yesterday, depending on the data. So the cumulative number obviously will keep going up because it's the number since the beginning.
Thank you. And that's important to note because for over the whole time period, that certainly is not an extensive number thus far. And we've been able to keep that load on the healthcare system in abeyance for a while. There are some more being seen all the time in that, and we continue to monitor that. We're building new metrics in our with our command table to monitor that situation there. We're looking at with now the cancellation of elective surgery with more beds, some being available, as well as admissions dropping and ED visits dropping with the advent of our assessment sites picking up. So this is all preparing, if you may, some room to move if we need to, as we experience a surge and a sudden increase in severity of cases in the community. So far, a lot of the ones that we're seeing are still coming forward with mild. The self-assessment tool is still being well used, and we continue to be informed by that. We know that, as I said earlier, the challenges with the people who have returned are in their peak period of time of incubation when they would be showing positive signs. And so, as I said before, the idea that we're having 80 to 90 or over 80 cases in a period is not surprising as we go through this time. The government reported last week alone we had 1 million people returning to Canada, Canadians from various sources, air and land transfer. So that is not an inconsequential amount. It's quite a large amount, and a large amount of that would be, of course, to Ontario. And we still have more returning in that. We have had some discussions at the federal level. There is increased concern about people maintaining proper social or physical distancing. And you've heard the Prime Minister and our Premier and Health Minister speak very strongly, which is I strongly concur with, is that we have to maintain that. We have to be consistent with that during these times especially. And while that's challenging, I say for the most part, I've seen a lot of people doing that, and I like all the creative ways that people are ensuring that it continues, whether it's in their household or they're doing things when they do have to go out and access retail, groceries and that, they're being very careful to respect the cashiers behind, and they have now put up some plastic barriers and various methods to keep themselves protected and to protect both the person purchasing and, of course, the person processing. So I think that's very positive in that way. One aspect that we continue to look at, we didn't mention the data there, is that our group from Trenton is decanting today from that. So they have, most of them, have completed their quarantine period. With the exception of the 13 people who became symptomatic while at Trenton. And there were 6 Ontario residents and 7 non-Ontario residents, and they will be released depending on when their date of onset and a time period afterwards. So, again, a job well done at Trenton in there, because while they attained positive, most people were kept with mild symptoms on the base. And are doing well, we understand. And so that was a combination of armed forces combined with the local health unit in that area, and the Red Cross have done yet another good job. So that was their third cohort through. And so I think in the business of all the rest, they might have gotten forgotten about, but certainly I haven't forgotten about them. And the excellent work they've done in consultation with Health Canada and the Public Health Agency of Canada in that regards. And for some of those coming out, it's been a journey for them, and I'm pleased that they're doing well. So there's that aspect there. Excuse me. We continue to have some outbreaks in some nursing facilities. We've heard, unfortunately, with the death. And that's the case there. We continue to monitor that very tightly. We've asked for restrictions, directed that people not take them out of the residence for that time, because that subjects them to a wider exposure. And also that people who have worked in multiple sites would make that known to their employers so they can make sure that they are not potentially spreading from one site to the other if it did occur. And we understand that some are, while we've allowed the staff to take some people outside for a visit, some are doing that as an opportunity to have very close contact with family members again, and that surprises me. I know it's something you want to do, but you have to respect and be careful, because these are our most fragile individuals and the ones we're most concerned about contracting COVID-19 and suffering morbidity and, unfortunately, in some cases, mortality. So you need to be really cautious and careful on that. in there. We know from across Canada, a number of our counterparts are dealing with a large load of cases coming in. They're featuring the same surge because it's the same travel issue, the same post-March break periods. And there is the lab testing capacity and backlogs in those settings as well. So we're all facing the same thing. We're looking at quickly ramping up. We hope to be up to 5,000 tests a day by the end of the week. And a number of the smaller labs have been there. They've done a total of, like today, just over about 950 tests among about 9 that are operating. So you can see some are doing a certain amount, some are just getting going because you want to start doing the first ones carefully, and then you can ramp up a lot more quickly as you get those aspects in place. So we're encouraged by that. We continue to work on the front across the board with personal protective equipment, various types. We're getting lots of good ideas, lots of volunteered and donations, so that's very helpful as we look at increasing our supply and stockpile to deal with any surges or issues and matters of concern therein. So we really appreciate the volunteerism and the various components that people are coming forward with in that. I should mention we've had some questions about the so-called rapid testing activities. These are new technologies. There's 2 types out there, and we're trying to understand those from our specialists at the laboratory. And both are being talked about. The one that's out in the market is a blood test, so it's called a serological test, and that one is available at this moment. The one that mimics or emulates our laboratory testing right now, the so-called PCR, or polymerase chain reaction testing, is not yet available. It's being promoted, but those ones are not yet out in the market yet. And the concerns with the serological testing is it's interesting data, but it's not useful in acute testing notification. We understand it's a positivity rate, or the rate of specificity, I should say. I'm wrong. Sensitivity is around 50%. So it's not great. It's an adjunct that one could use, but one would not want to depend on it solely to be your method of surveillance at this stage. So again, these are new technologies. They're not to be ignored. Some are point-of-care testing with the serology at this time. It can be a useful tool if you're in the hospital and you want to check some of your patients quickly, knowing that it has limited sensitivity, and you have to weigh that in your care and your overall assessment of your patient or client's situation. So we're in this now. This is another day, a Tuesday, in this 9 to 10 day period. I said starting from the weekend, going right through this week. This is a critical week. We have announced the essential services out there. The focus from my perspective all along is that if there's an essential service that we've deemed, the government has deemed that you can stay open and do that, the focus is still you need to do it in a way that maintains the social, physical distancing. So if you can do that while dealing with your staff, your employees, and keep them in that way, that's the most critical part. If you can do it with you're dealing with the consumer who comes to obtain those essential services, can you maintain that? We want you to maintain that. And can you put things in place, whether it's virtual handling, whether it's a physical barrier, or whether it's the distance one, gloves and certain things. There's all various components and unique settings that I feel that while the services are essential, you can still maintain that protection for the protection of the public and for your employees, and that's my strongest request as you stay open and seek to deliver these essential services. So with that, I'm going to open up for questions.
Okay, we'll take our first question.
Your first question on the phone comes from Antonella Artaso with the Toronto Sun. Please go ahead.
Good afternoon.
Good afternoon.
I wanted to ask you about your website. The Government of Canada website says that 48% of cases are deemed to be community spread. Mm-hmm. Local health units are saying that they know of evidence of community spread. Your own website says that the sources of infection are travel, close contact, and pending. Are you in danger of understating the risk of community spread by not naming it?
Our website also says that there's a percent, it's been rising from 7%, now the last one is 13%, that have no history of exposure or either through travel or case contact. So that those cases are there in that. Some would say that's evidence of community spread. It's terminology we use in various data points. The aspect there is that if you have a case that, as far as your investigation, has no known source, one has to assume they got it, as Dr. Yaffe said yesterday, from someone. And the thing would be challenged is that why can we find out who they got it from? Because there could be a clustering in that. If it's community spread, is it community widespread? Is it neighborhood spread? Is it institutional widespread? So these are all different terms that I think are important. If one talks about community spread, which version are you talking about? If it's community wide, that means you already have a high percentage of the whole population that's infected. That changes things totally. You will evidence that because with its normal epidemiology, you will start to see a number of those cases more and more showing up in the emergency department, more and more positivity tests going up higher and higher, and more admissions and more severe cases and more deaths, unfortunately. So we continue to monitor for all those aspects that might validate that does one have community cases that where either the person doesn't recall or doesn't know what they came in contact with. The health unit may not have had the time to do the investigation beyond that person as thoroughly as they'd like to because they have a lot of workload and they're trying to deal with the other ones. Or if there is community wider spread, how can one evidence that? And then, because that changes your method of handling that if you're going to do containment. So I think the aspect when I hear the numbers across Canada, when I talk to and look at the data from the peers from other provinces, as they have come on with more and more cases and the load, you will see that theirs is also that we have a lot pending, more and more pending, because that's a load that we're trying to look at how to enhance our public health resources to try and deal with that increased load, especially recently with all the travelers coming back and people we know and don't know, and that we'd have enough time to follow them up. So I think as they're dealing with that reality, as they may have more and more, they just don't have, they're pending or they don't have the time to investigate. One would have to assume if you don't know, then your one assumption is it could be community spread. But the fact that's based on that we don't know, not that we do know. So I know that sounds a little bit of a terminology one, but from an epidemiological standpoint, for me, if there's cases out there that we don't know where they got them from, I really would like to know where they got them from.
Okay, follow up?
Yes, please. Could you shed any light on what is happening in the correctional facilities? Is there any evidence of cases within those institutions?
I am aware of one worker, I believe, at one institution, but I know there's a lot of concern and fear, as there is among many people, particularly if you have to work closely with people. And we are working collaboratively with the Ministry of Solicitor General and the associations to look at how we can ensure that the workers and the inmates are protected as appropriate for their health and safety.
Next question.
Your next question comes from Allison Jones with the Canadian Press. Please go ahead.
Hi, this one is probably best directed to Dr. Yaffe. I missed off the top the percentage you said of cases that have come from the United States. I'm hoping you could give us that, and also talk a little bit more about how cases returning from the U.S. are affecting Ontario's numbers.
Sure. Of the cases that we have, which for 588, of those who traveled outside Canada, 29% came from the United States. And mostly New York, Colorado, California, Florida, and Nevada. How is it affecting our numbers? Obviously, it's a significant percentage. And, we're continuing to monitor. And right now, as Dr. Williams mentioned, with the influx of people coming back from the States, snowbirds and other people, it's something that we're watching. And I know that the federal government's considering more proactive measures at the borders, which is great. And, we're reiterating the advice we give to every international traveler returning, which is, stay at home for as much as you can, self-quarantine for 14 days. Don't go out, maybe somebody else can do shopping for you and things like that. So we want to make sure that they stay healthy and that they don't infect others.
Follow up?
No, that's all right. Thank you.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hello, doctors. Just wondering if you could give us a little detail of why these new powers for nursing homes today. So what do they, similar to what's been given to hospitals already, but what do they need to be able to do? Like, assuming this is all in the case of outbreaks, they can cancel vacations, they can move staff around, whatnot.
So do you want to talk about just general outbreak management and long-term care homes? Just the general, Rob was asking about the general procedures.
General management of outbreaks?
You're right. Go ahead.
Sure. Well, and I've said this before, the management of respiratory outbreaks, and COVID-19 is a respiratory infection, is one of the basic bread and butter things that public health does and has been doing for many, many years. And the public health units have a very good connection with the long-term care facilities in their local health unit, working with them on proactive infection prevention and control measures. So certainly working with them around identifying cases, determining what would make up a case, what's the case definition, increased case finding, making sure that any case is appropriately isolated and treated, obviously, if they need to go to the hospital, ensuring that there's a safe transfer and the hospital's identified to the hospital before the patient goes there that this is what it is. Infection prevention and control, cohorting, what we call cohorting staff, so that as much as possible it's the same staff that deal with the cases and it's not multiple staff. Trying to keep patients on the same floor that are infected, in doing contact management, very important to do cleaning and disinfection of surfaces. What have I missed?
You got visitor and staff movement.
Yeah, not allowing visitors or very minimal visitors if there's compassionate grounds, and using appropriate personal protective equipment for their staff when they're caring for a patient with COVID.
Follow-up?
Yeah, given that one of the cases last week, that man in his 50s who had first gone to the Milton Hospital and was diagnosed with pneumonia and sent home, and then later ended up in the Oakville Hospital and dying. I understand that pneumonia is not reportable as a public health disease, and I'm wondering if that might have helped, if it was reportable, it might have helped you get a better handle on this earlier, since a lot of people who are dying of viral pneumonia around the world.
Yes, I think the aspect there is we have coronavirus is reportable. More what you're asking for, and that's on our healthcare community with the physicians and nurse practitioners and different ones taking care of people on your differential diagnosis when someone comes in with a respiratory event, and you're assessing it on your differential diagnosis is COVID-19 one of your top ones or not. And of course the challenge you have there is that you want to order the testing and do it to ascertain. So if it seems like a person that doesn't seem to be at risk in your mind and doesn't enter your mind, then you won't order the testing or advise accordingly. You may be suspecting other organisms that you'd want to do with your so-called respiratory panel that you order testing on. And so I'm not sure what happened in the initial visit because it is regular flu season. There's lots of people with chest infections, whether it was ovarian pneumonia at that time, whether it was more of an upper respiratory or larger bronchials. I'm not going to get too much medical detail here. I can't say because I didn't review the chart. But the person did progress, and then when they went to the other hospital, the specialist did order a COVID-19, because that was on the specialist's mind, and that proved to be positive in that regard. So I would say it's more important it's on the differential diagnosis, that we call it, list for physicians, especially in this current environment. It would be one of your more top ones to do, and based on just its prevalence around, as well as there's other things in the history that would make you more concerned in that. So it's part of the challenge of doctors these days to put that in and to be suspicious of that right from the get-go.
Next question.
Your next question comes from Jeff Gray with the Globe and Mail. Please go ahead.
Hi there. Can you hear me all right?
Yes, we can. Thank you.
Oh, great. I just had a question about the criteria around the priority for testing. There are some people who say that the homeless, we've had 2 positive cases for homeless people in Toronto, that given the close quarters in shelters and so on, and the special challenges, that they should be given some sort of put into the priority group for testing if they have symptoms of COVID-19. I wonder if you could explain a bit around that.
Well, we have. You wanted to go on first because you're used to this in working your work in Toronto before, and
Oh, sure, of course. Well, I would say that the priority group for testing obviously includes people who are seriously ill in hospital with respiratory infection, healthcare workers, and people in institutions or group settings. And I would definitely say that homeless shelters are part of that group. So yes, they are definitely part of the priority group. They should be.
Follow up.
We're just hearing that they're not, but maybe you could expand a bit on that too. That are you concerned that enough precautions aren't being taken to protect homeless people in crowded shelters or other settings like that?
It's an ongoing challenge. Many years ago, I dealt with Toronto Public Health dealt with an outbreak of tuberculosis in the homeless shelters, and so it's a group that's at high risk for acquiring infection, and it's a group at high risk of having serious infection, serious sequelae, and it's an ongoing challenge to look at how you keep them not as crowded, with good infection prevention and control, good identification of infection, good access to care. And I know that certainly this is something that the operators of these institutions are very aware of, and they work very closely with the city or whoever's running them to do everything they can. I certainly, when I worked at Toronto, and I'm sure Dr. Davila could speak to this more currently, the health department works very closely with the homeless shelters to do everything that can be done to keep them as healthy and safe as possible, given all the challenges.
Next question.
Your next question comes from Haley Cooper with News Talk 1010. Please go ahead.
Hi, Dr. Williams. Hi, Dr. Yaffe. We still have some questions about nursing and long-term care homes. I know you touched on some of the restrictions and protocols that are in place, but we've been getting phone calls even to our newsroom from loved ones of people in long-term care homes saying that there's no social distancing that's happening. Residents are still sitting at tables together for all 3 meals. They're going to church services where there's over 50 people. And now that we're seeing these outbreaks and deaths, is it maybe not time to lock these facilities down?
Well, yeah, that's a good question. I think because we're trying to balance out if we're sure that the institution is, I would guess, I wouldn't say walled off, is tight around with no introduction of infection into the facility. If the staff are screened properly and the clients and visitors are screened properly, there's aspects in there because it's for a prolonged period of time. You want to be able to give care to these people. It is basically their home. It's residential at that time. And I know there's some with various issues in that where some contact with social is important. At the same time, if you put them all and keep them in the rooms for long periods of time, it's also difficult. So we're trying to strike a balance between the safety and the protection. If we're persuaded that there is good safety in the place, we're trusting the organization, the administration, to deal with that in a way that balances distancing as best as possible, allowing some aspect of course, you may have, it's easier for one staff worker to look after 3 or 4 or 8 people in an area. If they're sitting, they may not be maybe exactly 6 feet, but they may be a certain distance apart. We're trying to look at ways to do that in a way that's empathetic to the needs of these residents. because it's day in and day out that it is for them, and they're not having visitors coming. So that's an aspect you want to deal with. So I think there's a balance in there, and I understand some of the concerns. Not taking inappropriate risks. At the same time, we trust that the administration of those organizations is trying to seek the right balance with the risks that their home, if they're into, as Dr. Yaffe said, a case identified, it goes into a whole different protocol and different process. So they move rapidly on it. But again, I'm trying to balance the vulnerability of this group with their life health struggles they're in right now, and how to be sensitive to that and not lock them in a room for long periods of time on their own. I can understand why a family would be upset with that as well. So there's a balance in there.
Follow up?
Of course. And my follow-up is there still seems to be a lot of confusion about the people coming home from March break and self-isolation. Do those people returning from their travels have to self-isolate full stop, or can they go for hikes? Can they go walking in parks? Just clear up that confusion for us, please.
Okay.
Well, I would say they should be staying at home as much as possible. If they want to go out and take a short walk, just by themselves, or if let's say there's two of them living together, they can go out together for a short walk. But mainly they really should be staying at home and getting family or friends to bring them food or whatever they need for the 14 days after they return.
And I think the challenge you're trying to look at is there a difference between the self-isolation of a person who has come back traveling, who is asymptomatic, versus a person who has been identified as a case and is not in hospital. And in my mind, there is a difference. I think the case is going to have to be almost like you'd have similar to isolation in a hospital setting, where you are actually still secreting at that time, and you would want to be mostly in your room, being quite very careful hand hygiene. Some people may get a mask for that person to wear around the house in that aspect there. You should not be going out outside unless you're just by yourself sitting on your back of your house or something. So you're not really having contact with a lot of people if you can in that regard. The other one, we've allowed up to now a lot of self-monitoring. We've said that because you're asymptomatic, if you really had to go and get some medicines or medications or some urgent things, you could do that, so you're not so isolated. I think Dr. Yaffe's recommendation is as much as possible. Do the aspect of staying at home, short walks and outside that by yourself, or with if there's someone in your area, but you're still maintaining distance from your partner or family members if you can on that, to try and not give the potential if you might be incubating, assuming they didn't travel as well. If you're all travel together, you're all in the same grouping in that. So I think that's sometimes a bit confusing to people between isolation at home if you're a case versus self-isolation if you have a travel or contact history and you're asymptomatic for those 14 days.
Next question.
Your next question comes from Mike Hager with Globe and Mail. Please go ahead.
Mike, are you there?
Yes, sorry about that. Just wondering if you can tell us how many people in Ontario have been infected by the dental conference in Vancouver earlier this month, and your thoughts on that.
The data I have right now, I don't know of any cases that have been identified with that conference, or either reported from the site that held the conference, or from ones that we've reported. So I'm not aware of any at the moment.
Okay. And then also, we're looking at staffing in the healthcare sector. Is there an update on what plans are, or what may be in the works to address any short staffing that may occur as a result of workers isolating after testing positive, or even being symptomatic?
So our overall plan with our command table and with Ontario Health and our regional meetings is trying to address that issue. They're looking at the whole human health resource type aspect. Is there capacity to bring in, say, other part-time, or people are, especially, we still like them qualify if they're going to work in the health institutions in that regard, and can we certify them or train them back up quickly to come in to give an extra workforce in the need if it was heavily impacted. We're looking at some, especially with nursing otherwise, who may want to recertify or apply back to get their license through the college, and I think the college is trying to facilitate that so that we could utilize that. How would we use nursing students in that regard? They may be final year nursing students and other aspects, maintaining, of course, respect for their qualifications and with proper supervision. So there's many different things that people are looking at. Reducing the elective surgery, so you're freeing up more staff time with the latitude there. Looking at other sites for facilities and how do you staff those up. So I would say there's many different strategies on the go to look at scenarios and how you would surge up and handle that. The other aspect, too, is that we have the capacity to move some people around because the scenarios we have, not every part would be hit suddenly the same way as every other part. So there's that need to have these regional committees set up that they're doing with Ontario Health so that they can be assessing the situation currently, relating with the other ones around them, and can they assist them or not, and can they mobilize. So there's many different plans being put in place to try and deal with theoretical and potential and perhaps real surges.
Next question.
Your next question comes from Phil Perkins with CHCH News. Please go ahead.
Hi there. Premier Ford talks about seeing a light at the end of the tunnel. Are you seeing one as well?
Light at the end of the tunnel. I mean, we all assume there will be a light. If you look at China and some others that have weathered through, not without a lot of some challenges they had and deaths, unfortunately. So the virus itself, because of the way it transmits in that, has its limitations and aspects. People are often projecting that with the onset of some summer type seasons, a lot of our respiratory viruses seem to abate a bit. That can be that we get a better level of innate immunity among the public or different issues. So we might say that it could ease off that way. It doesn't mean it couldn't return again in the fall. So we have lots of theoretical models being proposed. In SARS, we anticipated it would have a big return in the fall. We didn't see that, but doesn't mean we're not going to prepare for that. So with spring coming in that, are we optimistic there could be some easing off? We'd like to think so. Right now, as I said, this critical time of these next 2 weeks, as I said last week and next week before, these times coming up, a period with all the people returning, with the number of cases happening in the United States as well as in Europe, and all the travelers coming back, is a real time of concern and monitoring for us, and we'd have to see what happens over the next week or two to get an idea of when, if there's a light or not, and what we'd have some idea of projection. And our modelers are looking to see what the data shows us as well. So I'm always looking for a light at the end of the tunnel, but I am trying to look at the data that might show us where that is and how far off it is, but we still have to monitor during these next week or two to see what's happening.
Okay, follow up, and I believe this is the last question.
And Minister Elliott said that they hope to have 15,000 tests a day done. At some point, when do you see us reaching that, doing 15,000 tests a day?
Well, we're looking we have a consulting group looking at that. We have many centers. We did, remember when we started, it seems a long time ago, 8 weeks ago we only had our public health lab. We now have added 9 others. We're going to add more even then. Each one is ramping up. We're looking at methods to, we have lots of swabs now and distributing those around. And now we're looking at the reagents. Can we acquire more of that quickly? And many different sectors are looking at how that production might be done to satisfy that need. So we have the labs surging up, we have the equipment ready, we have the training going on, we have the swabs, we need the reagent. So there's all different parts in it. We're optimistic that we'll get 5. We'd like to say definitely 10. I'd like to have 15 as well. And certainly with all things coming together, that would be reasonable and reachable.
Okay, thank you very much.